Okay, well, we have a very special guest speaker, and I saw that he was on the line, and I didn't say anything because we're going to do an introduction, a proper introduction for Dr. Favaro. But he is, as many of you know, you already know him because he's your doctor. But Dr. Justin Favaro of Oncology Specialists of Charlotte is researching new methods of treating lung cancer patients, including new advances in immunotherapy and targeted therapy. He is an investigator for a novel lung cancer trial involving a device that delivers tumor treating fields to cancer cells in the chest. Dr. Favaro earned an undergraduate degree from Clemson University. After completing an 8-year dual degree program, he received both an MD and a PhD from the Medical University of South Carolina. He completed his internal medicine training at the University of Texas, Southwestern in Dallas, and his fellowship training in medical oncology and hematology at Duke University Medical Center. Dr. Favaro is board certified in both medical oncology and hematology. His research experience includes basic science work in viral replication and tumor cell growth, as well as clinical research focused on trials that are testing new drugs for anti-cancer treatment. This guy's pretty impressive, isn't he? He co-authored a book on pharmacology and authored multiple articles in peer-reviewed medical journals. Dr. Favaro is the principal investigator on several active clinical trials. Please welcome our very special guest speaker, Dr. Justin Favaro. Thank you so much.
Thank you for having me. I really appreciate that kind introduction. It truly is my honor to speak to all of you today. As a physician, I'm constantly just enamored by the advances in the disease, and also humbled by what patients have to go through when they're diagnosed. We'll say that in terms of the co-author, the primary author of that book was my mother, so it was not too hard to be a co-author on that book. But we do a lot of research in our practice, including about lung cancer, and I'm just going to go ahead and get my slides set up, and so we can go through them. And I am guilty of doing too much in terms of slides, but I'll try to be efficient. And I also would love to answer any of your questions. So would you like to handle questions? I'm open to doing questions during the talk or after, whatever's better for all of you.
It's your call, Doctor, whatever you're most comfortable with.
Okay.
But I would ask everyone, if you're not asking a question, then please mute your device. Okay. Now, do I need to share the screen, or Lynn, do you have control? I'm not really sure.
I'm going to share my screen if that's okay with you.
Awesome. Yes, that's great.
All right. And I have some breaks built in so we can have some questions in the middle so you can remember. All right. So hope everybody can see me and hear me okay. So today I do plan on covering a lot of different topics, just touching on a lot of different things, hoping to stimulate thought, and then we're happy to answer your questions more detailed at any time. So what I'd like to talk about is just updates on cancer survival, which is great news, and then talk a little bit about treatment of early stage lung cancer before going on to talk about the different types of treatment for advanced stage lung cancer with both targeted therapy and immunotherapy. I will touch on briefly mesothelioma and small cell lung cancer, some experimental treatments, a little bit about our practice, and some tips on what to look for in the debate later tonight. All right, so national trends are good. What you're seeing here is the blue lines going toward your left indicate decrease in death rates, improvements in death rates going to the left. And you can see that lung cancer is the second leading cancer that had a decrease in the death rates, both in men and women. So things are improving.
Wow.
And over the last 7 years, or over the last 10 years, the death rates for cancer in general have decreased by about 15%. But if you really go back and look at over the last 30 years, death rates have decreased by 30%. And there's some reasons for that. One is more screening, but the second is the treatments are better. And what we're looking at specifically in lung cancer, because lung cancer survival has improved so much, and what we're finding is it's not just the screening and early detection, it's actually the effectiveness of the lung cancer treatments have gotten better. So any type of cancer is staged, okay, and stage 0, 1, and 2 are shown here. These basically are lung tumors found in the lung themselves that are still able to be surgically resected. Now, and stage 3A, I have a black line down the middle of the slide there because stage 3A represents more advanced tumors that can still be removed surgically. And then stage 3B and stage 3C are cancers that are still within the lung and the chest, but cannot be removed surgically because of safety reasons. So anything above the black line, stage 1 through 3A, the first line of treatment is surgery, typically. And then after surgery, if it's high risk, stage 1B, stage 2 or 3A, then it's recommended to take chemotherapy for 4 months. For 3 months. And if there's involvement of the lymph nodes in the middle of the chest, then radiation therapy is also recommended. For stage 3B patients and stage 3C, it's a little bit different. I'll talk about that in a second. And so this is some recent data that came out of the national meeting in ASCO in Chicago, looking at patients that have an EGFR mutation. And we'll talk more about that. But if the lung cancer has this particular mutation, after you go through your surgery and your chemo and your radiation if you need it, if you take the drug Tagrisso for 3 years, you basically reduce the chances of the cancer coming back dramatically. And so the patients, it's a doubling of the patients that don't have the cancer coming back if they take this oral medication. So that was really new information, but it definitely changes how we treat that particular case. Now for stage 3B, I mentioned those are still within the chest, but cannot be removed safely surgically. Those are treated with chemotherapy concurrent with radiation therapy. And this most recent study here, looking at the use of immunotherapy for 1 year after completion of the chemoradiation therapy, led to a 30% improvement in survival. And so that has also changed our management of how we treat that disease. So you can see here, when the cancer is in the lung, we really strive towards surgery for most, and if we can't do surgery, then chemoradiation therapy followed by immunotherapy. Now, I want to move on now to talk a little bit about treatment of stage 4 lung cancer that is metastasized outside of the chest. And everybody knows what chemotherapy is. And basically, chemotherapy is a drug that goes into your body and really attacks rapidly dividing cells. And so if you see, this is a lung, typical lung, and these circles represent cells, okay? And so the blue ones are normal cells, and the red cells are the cancer cells. And if you see a circle around the cell, that means that the cell's been killed. And so what happens with chemotherapy is it goes into your body, it's rapidly destroying many of the growing cells. The cancer cells are being killed, but also the normal cells are being killed. Now, targeted therapy, which we'll talk more detail about, really is like a smart bomb. It goes into the body and it really specifically hones in on the cancer. It really does not cause as much damage to other parts of the body. So one of the first targeted therapies in lung cancer was EGFR inhibitors. And so I mentioned this earlier. And in a certain subset of patients, it's probably anywhere from 5 to 20% of lung cancer patients, the cancer cells are driven by EGFR. Okay, this is a protein that's on the outside of the cell. You can see this cancer cell here. This is the EGFR protein on the outside. And this protein causes this cell to grow, to divide. And so we figured this out, the scientists figured this out, and they developed a drug to block that protein from working, okay, so the cell dies. And that really is dramatically effective in killing these types of lung cancer cells. And there have been multiple brands approved for this. The most recent and the most effective is called Tagrisso, which we will typically use in those patients that have had surgery or in stage 4 lung cancer patients. So the EGFR pathway was really the first one, and that even when I was in training, we started to understand that about 15 years ago. We've come a long way. It's not just one thing that can drive these cells. And this is really just a very simplified diagram of what a cancer cell looks like on the inside and the out. This is the outer barrier of the cell. You have all these different proteins on the outside, and you have a lot of different proteins on the inside. And not just EGFR, but many different proteins are stimulating those cancer cells to grow. And so that in turn allowed the scientists to try to develop drugs to specifically knock out some of these proteins so we can stop those cancer cells from growing. And that has led to just a boom in the number of pills that are targeted to those specific cancer cells for lung cancer. And I'm just going to go through just a few of them here. And there's some of these pills have multiple brands, okay? But for those patients that don't have the EGFR mutation but have an ALK mutation, the pill Alecensa is typically used for the first line of treatment. For those patients that have a ROS mutation, Roseltrek is a first treatment. And then you have the treatment for RET mutations, and then you have the treatment for MET exon 14 mutations. And it goes on. And some have mutations in a protein called BRAF, uses a combination of these two pills up here, Talnafar and Mekinist. Believe it or not, some lung cancers have mutations in HER2. If anybody's familiar with breast cancer treatment, Herceptin is a very common treatment for breast cancer. We can also use this in some mutated lung cancer patients. And this is an even newer drug for some that have the NTRK mutation. So this has just been, represents, these two slides represents just a few years of research, but it's brought to the table so many options for so many patients that we never had before. It's almost like we call it an embarrassment of riches, so many different options, which is great for those going through this. So how do we figure out what mutations you have? Well, obviously we can always do a biopsy, never fun to go through. Now, for the first time, there is an FDA approved blood test. And believe it or not, the cancer cells are circulating through your blood. And so we can draw the blood out and send it off to the company. They can detect those microscopic cancer cells in your blood, determine which mutations you have, okay? And we can use that as almost as good as actually doing a biopsy of the cancer. So this is called Guardant 360. Many of you may have already had this test done. And I want to show you an example of just how interesting this is, but also, this is getting pretty complicated as well. So I'm going to talk about this patient of mine who gave me permission to use his scans. And he's 55, diagnosed with stage 4 lung cancer. He had the EGFR mutation. This is his PET scan. I'm just going to show you one piece of that, just to show you that he had multiple spots of cancer in the bone here. The bright spots that show up on a PET scan are the spots of cancer that you see here. Now this down here is the bladder. That's normally bright, so that's nothing wrong with that. On this particular view, we don't see any other spots of cancer, but just for purposes of illustration, I'm just showing you this one spot. So this one scan. So he was diagnosed, and about almost 2 years ago, he was placed on Tagrisso, the oral treatment that targets the EGFR mutation. And he did well for 18 months. And 18 months later, what happened was a lot of these spots that you see here went away, right? But there were some new spots. You have some new cancer around the hip that was causing pain, a few new spots in the back that were causing pain. So at that point, we switched his treatment. We said, okay, let's change you over to chemotherapy. So we stopped the Tagrisso. We started him on a combination of chemotherapy and immunotherapy, okay, something that's very commonly used when Tagrisso is no longer working. Now, we took this for 3 months, and there was some improvement. but there was also some worsening of his pain. And just after 3 months of treatment, what we saw here were, yes, indeed, some of these spots had gotten better, but there were some new spots. And you can see here on this PET scan that there were new spots in the back and also a new spot in the adrenal gland. And then we decided, well, what are we going to do? So we actually went back and looked at the Guardant 360. So remember this blood test that looks for these specific mutations in the blood. And so we did that on him and we looked at the numbers, okay? And what's interesting to me is that after we gave him the Tagrisso, this mutation in his bloodstream is very low. Okay, so I would expect that. I would expect that if you give them the drug, the mutation and the number of cancer cells expressing this one is low. Now, I don't have the exact number of where it was when he was first diagnosed, but I'm assuming it was probably about 50%. So it probably went from about 50% down to almost zero on this drug. Now, after 18 months, he started having new spots of cancer, and that EGFR mutation had come up a little bit. So we decided at this point that his cancer was resistant to the Tagrisso, and we switched him over to this chemotherapy and immunotherapy. And look what happened. Just after 3 months of coming off the Tagrisso, the number of mutations in his bloodstream skyrocketed from 4.5% to 34%. Okay? And so this means that the cancer is very complicated. In one person's body, some of the cancers have this mutation and some don't. And so the treatment for him was to continue the chemotherapy, stop the immunotherapy, and add back the Tagrisso. And so that's what we've done. And so we've actually done a combination of chemotherapy and targeted therapy for him. And this is all pretty new. I did all this week for him, but we did this about 2 weeks ago, and his pain is better. And so I think that this is working. And so what it means is that we're getting smarter, but we're realizing that the cancer tries to outsmart us, and so we've got to be creative in how to outsmart the cancer. And this is probably what's going on in a lot of patients' bodies. As we give treatments, the cancer tries to find a way to outsmart us, and then we have to, find creative ways to get the next treatment that will work. Okay, so this is what we're looking forward to in the fall here in Charlotte. And I thought I'd just take a time. This gives me a chance to take a little bit of a break and see if you have any questions. Just to summarize, we talked about early stage lung cancer, we talked about the treatment for that, we talked about targeted therapy, which really targets those specific proteins in the cancer cells. So any questions at this time?
If you want to ask a question and you're muted, if you just press your space bar, if you're on a laptop, then you can talk. Otherwise, Lynn, can you unmute?
Yes, I'll tell you, I'm going to scroll through. So raise your hand if in the chat down here, you can also raise your hand. But if I see you, because we muted everyone, there was some background noise, so we had to mute everyone, guys.
We are recording this.
Yeah. Any questions?
Well, this is what
I would like to ask a quick question. You heard Terry Conneran talking about KRAS, and I just wondered, would you like to share just a little bit about what's going on with KRAS?
Love to. Yeah, that's exciting. So KRAS targeting is a very area of very active research, and there's a lot of different clinical trials looking at that, and they're looking to be more and more successful. The closest KRAS inhibitor we have is from Amgen, AMG 501, or actually AMG 510, I believe. And this is an oral drug that actually targets a specific KRAS mutation called G12C. And that has looked promising. Amgen came out with a recent press release this week showing some good effects of this drug in lung cancer patients that have this specific type of KRAS mutation. And so that's close to market. But there's a long way to go because that only represents a small percentage of them. But that's a very active area of research.
Thank you.
Dr. Favaro, it's pretty common, isn't it, for targeted therapies to work for, say, a year, 18 months, a couple years, and then stop working? Is that right?
Right, I think the duration is dependent on the drug and the particular mutation, but that's exactly right. We do end up seeing that resistance develop, and it may not be resistance of all the areas of cancer, but maybe resistance to some of the areas. And then that's how we end up having to go back to chemotherapy for those situations, and even immunotherapy, which we'll talk about in a few minutes. But it's a dynamic situation, because when you do that, you can see some of those sensitive cells to the EGFR inhibitors come back. Like in that last patient, the cells that were sensitive to the Tagrisso increased to 34%. So it allows us to do a combination. We can combine chemotherapy with the Tagrisso in that situation and get some clinical benefit.
I have another question about, so we know that, there's a small percentage of patients might have ALK, a small percentage might have RET, a small percentage, but when you combine them all, what are the chances of a lung cancer patient having a targetable biomarker?
Yeah, it's great. So I think I'm going to guess it's close to 20%. I don't know the exact number, but it's obviously increasing the more mutations we find. And it's more common, these mutations are more common in non-smokers, but I've seen them in smokers as well. Okay. All right, so on to immunotherapy, which is a very hot topic in lung cancer. So how does immunotherapy work? Well, cancer shuts your immune system down. And as we learn more about COVID, we're learning that the immune system in cancer patients is not what it is in patients that don't. And so what happens is that the cancer cell, which is represented here, has specific binders or proteins that turn off the immune system cells, okay? And so the researchers developed these drugs that interfere with this communication. And so now the immune system cells are not turned off. In fact, they're turned on, they're angry, and they come after the cancer cell and kill it. So that's really the paradigm for almost all the immunotherapy we'll talk about. And everybody's seen the commercials. Opdivo and Yervoy and Keytruda are the big ones we use. There's also Tecentriq is another immunotherapy. And so here's an example of a patient who came into me with lung cancer. His lung cancer was stage 3B. He presented about 2 or 3 years ago, and this is if you're familiar with PET scans, as we looked at before, this is a picture of his PET scan. This is a cancer here with lymph nodes involved. He was very adamant he did not want chemotherapy. So we were able to get the insurance company to pay for immunotherapy alone. And this is back when it really wasn't approved for that, but we were able to do it. He took just 4 treatments, and he got a lot of side effects. He had to end up in the hospital because he had inflammation in his abdominal area caused by the immunotherapy. But he recovered from that, and his cancer really went away. In fact, I saw him back today, still no sign of cancer 2 years later. And so we're trying to still understand which of us will be able to respond well to immunotherapy, which of us will not. But you can see, obviously, we can have some good success. And so how do we determine what to do? So there's a lot of different options. This is a recent trial combining 2 different immunotherapy drugs with chemotherapy. But the interesting part in this was there's only 2 cycles of chemotherapy given, okay? After those 2 cycles, it was just plain pure immunotherapy. And that study was compared to just chemotherapy alone. And so the gist of this was that if you combine them, chemo plus immunotherapy, it improves survival by 50%, and with less toxicity, obviously. You hear a lot about what's called PD-L1. PD-L1 is a receptor on the cancer cell, it tells us if it's there strongly, it tells us the immunotherapy is going to work well. If it's not there so strongly, it doesn't always work as well. Well, for this particular regimen, it doesn't matter. If you're PD-L1 positive or PD-L1 negative, we still have benefit. And so this is rapidly becoming one of the more common regimens for first-line chemotherapy. And this is for stage 4 patients who don't have a receptor mutation, who cannot take the targeted therapy. But of course, there's many other options. This is a combination of 2 different chemotherapy drugs, carboplatin and Alimta, plus the immunotherapy drug Keytruda. So a 3-drug combination, adding the immunotherapy to the chemotherapy doubles their survival. This is another combination looking at squamous cells. So as you know, there's 2 major types of non-small cell lung cancer, adenocarcinoma, which we talked about with the previous slide, and this one is squamous cell carcinoma. So a combination of carboplatin plus a different chemotherapy, Abraxane, plus the addition of immunotherapy. The addition of immunotherapy improves survival again by 50%. So another very common regimen. And there's others as well. There's different ways of combining these. But the bottom line is that, you know, for most patients that are healthy enough, that don't have one of these specific mutations, the standard of care is quickly becoming chemotherapy plus immunotherapy. Now, there are some that either don't want chemotherapy or are not able to handle it. And if we do see that if the PD-L1 is greater than 50%, they can do just as well with immunotherapy alone. And so that's often another option for those. And that was what I just described here about those patients that have the PD-L1 greater than 50%. The immunotherapy alone, Keytruda, doubled the survival. And so who will it work for, who will it not work for? And that is another area of intense research. This is called a swimmer's plot, and what it basically represents is individual patients. So each patient on this trial is represented by a line, okay? And this is how long they live without the cancer coming back. So you can see that, and this is not really related to these previous studies. I'm showing this as an example, that in this particular study that was done, let's say you had about 30 patients. Well, there's about 6 with the arrows still going, maybe a few more, maybe 6 or 8, with the arrows are still going. That means that they're on the treatment, it has not come back, and what we usually do in those situations is we treat for 2 years and then stop. And most of those patients, their cancer doesn't come back. And if it does, we can retreat and usually have success. So we're seeing you know, a certain percentage, and it's not, right now I would say it's, depending on what study you look at, it may be 15, 20%, maybe a little higher in some cases. So around that range of 15, 20, 25% of patients that really can have a long, durable response to immunotherapy. But then there's the others where it doesn't, and we're still, the PD-L1 is one way we're trying to differentiate that, but there's obviously a lot more to the story, and that's really where a lot of the research is heading, is what about those where the immunotherapy doesn't work, where there isn't a targeted therapy, what are those options? All the treatments I've described have side effects, and we have to be very careful. The good thing about immunotherapy side effects are that we can reverse them quickly with steroids. And there's basically anything that can be inflamed in the body, which is any part of your body, can be affected by the treatment. And so you can have inflammation of the eye, rash, inflammation of the liver. You can get some neurologic symptoms like myasthenia gravis, inflammation of the lungs, diarrhea. We often see low thyroid or high thyroid, pancreatitis. These are rare side effects, but all these things we look for. If there's an issue, we hold treatment, we put on steroids, and they can get better. So break number 2 is to help you think about what we just talked about today. So far, was just basically looking at immunotherapy, how it works, the different treatment options depending on your PD-L1 status. We went up to Grayson Highlands State Park recently, and this is just across the border from North Carolina in Virginia. And my daughter loved the wild horses that were there, pretty easy to find. So just another break to see if there's any further questions on what we talked about so far.
I think at the end of our last break, Dr. Favaro, I think Elizabeth, did you have a question? And I'm going to go ahead and see if I can
can't see if there's anything typed in, I haven't been able to see it.
Right, there we go.
Yes.
Elizabeth?
Two questions. The liquid biopsies you were talking about beforehand, are they capable of detecting cells with all targetable mutations, or which targetable mutations can they detect?
Yeah, they can detect all the targetable mutations that we know of. And so there's pretty wide-ranging number of mutations they can detect. Yeah. I don't know if there may be an exact number to that. I don't know what that is, but anything we've talked about that has a potential drug target, a drug that can directly target that mutation, the Guardant 360 is looking for that.
Do you ever see with those liquid biopsies a change from one target clone to another targetable clone?
Yeah, no, that's a great question. I didn't, when I presented that slide with that one person where you saw the EGFR mutation go up, that was interesting, but there's other things that can happen, right? So other mutations can actually go up in the setting of a targeted therapy. So for example, another way that can happen when you take Tagrisso is that the EGFR mutation goes down and then the cancer develops what's called a MET mutation, either a MET amplification or a MET exon 14 skipping mutation, other things you may hear about. And that's actually a mechanism of resistance to the Tagrisso. So then if you see that, you can consider moving in with a MET inhibitor, which was just approved. And so that's an example of how that can happen. But absolutely, you can see different mutations come up.
And you had mentioned with some of the immunotherapy, actually stopping it at some point in time and seeing whether or not there was recurrence of the cancer. Is that ever applicable in targeted therapy?
The paradigm in targeted therapy is a little different. What typically happens is you start it, it works extremely well. You may see the PET scan go completely normal. But that's typically a duration of anywhere from, depending on what your target you're looking at, 9 months to 18 months. Typically you do see resistance develop. And that really is a challenge of how to manage those patients at that time. There's been some studies looking at specifically, because a lot of these mutations are new, we're still learning. With the EGFR mutation, we have a little bit more experience of looking at using a combination of chemotherapy and immunotherapy in the setting where the cancer becomes resistant to the Tagrisso, the EGFR inhibitor. And that's what we did for that patient. And that's been shown to have some benefit in patients like that. And so we're looking more and more at that. And so you can incorporate immunotherapy to some of those patients. I've not seen anybody have a long, durable benefit from that, but there may be examples out there of that.
Thank you.
How do you know if you're a good or a bad candidate for the immunotherapy? Are there some patients that just, it's not a good thing for them?
Right, yeah, so that's another great point. And so anybody that has an autoimmune condition or has had a transplant, an organ transplant, you have to really be careful. And so I do use immunotherapy in some patients that have rheumatoid arthritis, and it's surprisingly well tolerated. Those that have lupus, which can be more serious, we tend to avoid it. But there are examples, and for example, if you've had multiple treatments for your cancer and immunotherapy is something you haven't had, you may be more willing to take a risk. And so sometimes there are compromises made. Even in some patients that have had kidney transplants, immunotherapy has been used. Many of those patients do not go through organ rejection, but some do. In general, it's been avoided in heart transplant patients. because of the risk of organ rejection or lung transplant patients. So we know that, at least in heart and lung transplant patients in general, it's not done. But the other autoimmune conditions, it can be done. We have to be very careful. And sometimes instead of using 2 drugs, we'll just use 1 drug, maybe spread it out more, see how they tolerate it. But I have at least one person I can think of that had pretty severe RA, but he had stage 4 melanoma, and he took immunotherapy for 2 years, never had any major problems, and is now off treatment doing well.
And then the other part, well, actually, I've got 2 more questions. One about the liquid biopsy. Is there a way that they can track how well you're responding to a medication using that?
Mm-hmm. Yeah, and so we see usually what happens is if you're starting targeted therapy for a specific mutation, if you look at the liquid biopsy, that mutation level is going to be pretty high in your body, okay? And so when you start the treatment, take it for 3 months, you're going to see that amount of mutation go down. So you'll be able to track how well it's working. And also at the same time, if the cancer starts growing back, you may still see it remaining very low because now the cancer has got new mutations or other mutations may come up that may be taking over. But yeah, you can definitely use the liquid biopsy as we did with that patient to track. And I didn't have the initial result when he first got diagnosed, but I'm assuming it was around 50%. So he probably went from 50% down to almost 0 by taking the targeted therapy.
So that would pick up if he mutated into, from EGFR, he went to the exon 19 or whatever, right? Well, it sounds like it's very important to know what your biomarker is or what it is that's driving your cancer. How do you normally, I know just like in the community, I'm asked, how can I ask my doctor about it? How do I know if it's been done? How do you kind of like address that with patients, or how can we ask?
Yeah, so whenever you get diagnosed, you have a biopsy. So you always want to ask, do they do what's called genomic testing, okay? Genomic, genomic. Always ask if they do genomic testing on that. And that will include the PD-L1. That will include all the mutations that are important, okay? Now, when you're also diagnosed, I would also recommend you get what's called the liquid biopsy, what I talked about. That company, there are several companies that do it. The main one people are using is called Guardant 360, and that's what I was doing with that patient. So when you're diagnosed, you want 2 things. You want the biopsy with the genomics of the actual tumor, you take a piece out and send it to the company. You want the lab test, and same thing. You're basically doing the same thing on both. You want both pieces of information. And then as you go through your treatment, and you do repeat scans, I think it's a good idea to get the Guardant 360 every time you get a scan. And then you'll see what's happening. Where are my mutations now? And you should see that mutation that was very high come down, okay? And it typically does stay down when you're on treatment. But if you're, when you get the scan done, if there's new spots of cancer that may have developed, well, maybe there's resistance, maybe there's a new pathway that's being generated. So you want to do the Guardant 360 with those scans so you can see what that is, and then that will kind of give you some information that you can use to choose the next treatment. But the main thing.
Favaro,
Go ahead.
I didn't mean to interrupt. I thought you had
No, I'm
answered
good.
the question.
I'm
I'm just wondering about, they only are testing, they're doing the comprehensive biomarker testing only on the advanced stage patients. Is that correct? Or could you address that?
That used to be the way it is. Now with this new study that came out over the summer showing that you can actually take targeted therapy after surgery for patients that have EGFR mutations. So now even the earlier stage patients are getting the testing.
I'm so happy to hear that.
Yeah, that's really encouraging news. All right. Move on then. So mesothelioma is a very rare type of lung cancer caused by asbestos exposure. The typical treatment has been chemotherapy. Recently, that we've added bevacizumab. That's a drug that inhibits blood vessel growth into the tumors, and that can be beneficial. That drug is also sometimes used in the traditional type of lung cancer as well. Recent studies have shown that chemotherapy plus tumor treating fields, the alternating electrical currents, and I'll discuss more of that in a few minutes, has improved survival. And finally, in mesothelioma, immunotherapy was recently shown to be 30% better than chemotherapy. So a previous really tough cancer now has 3 new options that we didn't used to have. The last type of lung cancer is small cell lung cancer, and that is obviously different than non-small cell. This is a less common type of lung cancer, but it can grow very quickly and needs to be treated appropriately. The standard treatment is chemotherapy plus immunotherapy. And the recent addition of immunotherapy has improved survival. After that stops working, there's a new drug, a new chemotherapy drug called Zepzelca, and this is very well tolerated. That has a good response rate in about 1/3 of patients. And so these last 2 types of cancer are not as common, but we still need a lot of research done to improve outcomes, and we're starting to see some improvements there as well. Now, sometimes some may ask if you see the mutations in these other types of lung cancer, and occasionally you can. And very rarely you can see a non-small cell lung cancer transform into a small cell. And you can actually sometimes even see the mutations in that. So sometimes you can use the targeted therapies in combination with other treatments in this disease as well. So I want to talk about a little bit more about clinical trials and research. These are just a few of the articles I pulled off about new things that are coming out. This is interesting. This is a drug called trilaciclib. I can't pronounce it. Trilaciclib. This is a drug that's used in combination with chemotherapy in small cell lung cancer. And what it does is it reduces the toxicity to the bone marrow. And so one of the problems is, blood counts go down, the immune system goes down. This can help preserve the bone marrow to allow you to get more treatment, which is pretty fascinating. This is this Amgen drug, KRAS G12C inhibitor that I talked about that had some positive results that just came out in a press release. There's a bunch of other proteins in the cells that the companies are targeting. And we're going to go back to tumor treatment fields in a few minutes, but these basically is a medical device that generates alternating electrical currents through the tumor. Okay, that's been proven and is actually FDA approved for both brain tumors and mesothelioma, and it's being actively studied in lung cancer as well. And this particular study just was announced, a combination of tumor treating fields plus immunotherapy for first-line lung cancer patients. And this is a trial we're working to get. They're going to start accruing patients in 2021. More clinical trials looking at combining immunotherapy with other things, right? We want to make immunotherapy work on 100% of the cases, not where we are now. So they're adding other oral targeted agents to immunotherapy. This one is called cabozantinib, which is often used in kidney cancer. And there's also targeted treatments using other anti-angiogenesis drugs, such as ramucirumab, in combination with immunotherapy. So the combinations are coming out, and that's where I think we're hopefully going to push that curve and get more and more long-term survivals. And so we do have clinical trials in my practice. We are looking at a targeted therapy called pemazirine, and this is a oral drug that targets FGFR receptor 1, 2, and 3. This is a drug that's actually FDA approved for the treatment of 2 different types of cancer, cholangiocarcinoma, which is cancer of the bile ducts, and also bladder cancer has a similar drug as this. And we're looking for these particular mutations in the lung cancer patients. And if we find one, we can try this oral treatment as well. And I want to talk about a little bit more about these alternating electrical fields and the clinical trial we have at our office, and a little bit more about how these work. And so whenever you have a cancer cell and it grows, what happens is the cell has to divide. And there are a lot of proteins that have to align in the middle. The DNA has to go to each side, and the cell has to divide into two. And that's what cancer cells do best. They're continuing to grow and divide. But if you put these cancer cells in the middle of an electrical field, what that does is it changes the polarity of all these proteins in the cell. So instead of having orderly division, cell dies. Okay, and so we've known this for a long time. I used to grow cancer cells in culture when I was doing research, and we would see that these cancer cells would not grow very well if they're inside an electrical field. So taking that research and applying it to patients is what this particular clinical trial is. And so this let me show you one other picture here. So this device is a set of electrodes that are put on the skin over where the cancer is. And what happens is these electrical fields go through the tumors inside the body. You don't feel shocks, but you do feel warm as that happens. And these electrodes are connected to a power generator. So this technology is, as I mentioned before, it's approved. And so this patient, if they had mesothelioma, you could run it through the insurance, and the insurance would pay for it. You would basically just supply them this device in addition to their standard chemotherapy. And also we're doing the same thing for people that have primary brain tumors, such as glioblastoma, where they put the electrodes on their scalp and they shave their head. Okay. So at our practice, we're screening patients that have had stage 4 lung cancer that have been through initial treatment and randomizing. And some patients will get treatment with the alternating electrical fields, and some patients will just get their plain treatment. And so we're studying to see what the difference is in terms of outcomes for that trial. And these are just actors portraying it, but you can, once they have it on, they can walk around with their generator in a backpack or on wheels, and they can accomplish most of what they want to do. There is a weight to it, and so if somebody's weaker, it may be harder for them to do this treatment. I think this is a nice, kind of a fascinating way to add another mechanism of action to the cancer treatment, because you can tell in the slides I've shown you before, the cancer cells are constantly trying to evade and to outsmart our treatments. And so the key is, how do we combine, and what do we combine together to try to kill them completely so they can't do that? All right, so and so just another break. I've talked about some clinical trials and experimental treatments. We've really covered a lot of space here in terms of early cancer treatment, targeted therapy, immunotherapy, and clinical trials using some of this new technology. And so we're looking at opening up, hopefully, 2021, the immunotherapy alternating electrical field trial in our office. And I think if you're in this situation, there's a lot of options. And you always want to think about what's going to work the best for you now. And that's usually standard treatment, but at some point, there's often a time when you think about a clinical trial, something else we can do, whether it's been proven or not, but we want to see if this can help you. Any questions at this time?
I am so excited about this TTF field. Honestly, I'm just like over the moon excited about it. I mean, it's got all the things I like. It's techie, it's cool, it's not chemo, it's like really neat. So how long does it take to actually see a response from one of these things? Yeah. And I'll just keep pelting you with questions over this if you want to know the truth, because I just think this is so intriguing.
Yeah, it's amazing. I mean, I think I can tell you our experience, because what we know is what we've done and what's been proven. So they initially started using this in brain tumor patients. And in that way, it's a little bit simpler because the tumor is just within the skull, right? And so patients would shave their head, they put the electrodes on, and the goal is that they would wear them up to at least 18 hours a day. And longer the better, but at least 18 hours a day. So they'd have to use a gel and apply them. And then and the company really helps a lot. They actually will map the tumor in the brain, and then they will take the electrodes and place them at the appropriate places on the scalp to maximize the electrical fields going through the tumor. Okay, so that's how it all works. The company works in conjunction with the patient and the doctor to map it and to put the electrodes on appropriately. And somebody will actually come, you can meet the patient at the clinic. We have somebody here local in Charlotte and show them how it works and help them if there's any complications. And they actually did 3 different studies in patients with brain tumors, and the patients were still getting their treatment. Okay, they were getting either an oral chemotherapy or an IV chemotherapy, and they were just adding on this device to everything else they were doing. And they saw consistently about a 6-month improvement in survival for that disease. And so that's where it really started. And obviously, you know, the concept was there in the lab, and it is fascinating to see it just translate into benefit. And so now, I actually spoke to the rep today. We have a good relationship with the company, and they of course did the trial in mesothelioma. And so instead of putting the electrodes on the scalp, they put them on the chest, you know, close to where close to where the tumor is, close to where the tumors were in the body. So if there was a right-sided mesothelioma, they'd put the electrodes around the right side mostly. And the patients would still get their usual treatment, and they saw an improvement in survival with that as well. And so now they're looking at doing non-small cell lung cancer with the trial we have open. They're looking at combining it with immunotherapy. Again, why is it only 10, 20, 25% of patients get benefit? Why can't we make it 75 or 100? Will this technology work in conjunction with the immunotherapy? You know, it's just unknown. But it seems to work in conjunction with other treatments. And they're looking at other diseases as well: pancreatic cancer, ovarian cancer. They're looking at lung cancer that's spread to the brain. They're doing treatments in that as well. That's part of a clinical trial. And so all these things are now being looked at because of the initial success they had.
That's super exciting. Are they doing anything in, like, say, small cell as well? And what are the side effects?
Yeah, I don't know about small cell. We went through everything today. I don't believe they said it. I think they should. And the side effects basically are, you know, just some skin irritation. Some will have that, where we have to get a dermatologist involved to try to use some steroid cream to the areas where the electrodes and the gel are going on. It does heat up a little bit, so there's some warmth to it. You're wearing it at least 18 hours a day, so kind of the inconvenience of it there. It's a pretty light pack that you can carry around. I think it's around 5 or 6 pounds, maybe lighter. There's a new version that came out, so just having to deal with that. But there's no nausea. There's no additional worsening of your chemo side effects. It's just the device itself.
Okay, and then one last one. Okay, so if I thought that maybe a clinical trial might be the right thing for me, how would I go about finding out what I could do or where I should go? Do I hit my doctor up with that? Do I come talk to you? How does it work?
Yeah, we're happy to talk to you anytime and see if you're a candidate. You always want to kind of know if you're a candidate for these trials. The current trial we have open, they're trying to change it, because when it was written several years ago, nobody was getting immunotherapy at the beginning, okay? And so the way the trial was written is you couldn't get immunotherapy at the beginning, you had to get that later. And that's not the way anybody's treated anymore. So now they're going back and having to redo the inclusion criteria. And so that's a process that goes through the FDA. It may take a few months. So you always want to make sure you're a candidate. You're always welcome to call the doctor's office and talk to their nurse and just kind of explore that before you end up coming. You know, Novocure has got a website, and they've got all the clinical trials listed there. So if you're looking specifically for that, clinicaltrials.gov is a great site, and that's basically going to tell you, you know, where the clinical trials are for specific disease types, and you know, because there's so many going on now. I mean, when I would go to the annual meeting in ASCO, the last one we had in person was a year and a half ago, and I mean, you would go in, you go to Bristol Myers Squibb or Merck, these, you know, big companies with these immunotherapy drugs, and they would have this huge board, you know, full of clinical trials. I mean, hundreds of clinical trials combining these oral drugs with immunotherapy, you know, multiple different combinations. And so it is challenging to know what's really best for you. You know, you don't, I mean, it's hard. You do rely on your physician, but you can always do your own research, and especially you can even look locally at the different cancer centers in your region and see what's going on. And some of them have good websites, some of them don't. But you know, I think it's important to look at that and know when the appropriate time. I'd always try to use the guidance of your physician who knows you the best, because there's a time to hold them and there's a time to show your cards. I mean, there's a time to do these trials. There's a time when standard cancer treatment is still the best option for you. So really close collaboration with your doctor, but do your own research on the websites and clinicaltrials.gov.
I'd like to jump in and just add a note to that, Dr. Favaro. The Lung Cancer Action Network just entered into a partnership with Stand Up to Cancer, and they are, Stand Up to Cancer is funding it. It's a clinical trial navigational services. It's free of charge to all the members of LungCan and all the lung cancer patients. So that link we will distribute to everyone, but you know, it's personalized navigational services, because the clinicaltrials.gov website can be overwhelming to a lot of people, but thank you so much for that. And I have a couple more questions too.
Sure. That's a great service. I didn't know about it. That's great.
One thing is, and I apologize that I should have asked this sooner when you were on there, but anyway, are there any targeted therapies for squamous cell, or is it only adenocarcinoma?
That's a great question. Yeah. The mutations we don't find as often in squamous cell. I found them though. I send these tests on everybody. And you will find occasionally, probably about 1% of the time, you may find some of the mutations in squamous cells. And the reason is because sometimes it's not just squamous. I mean, it can be mixed. You can have squamous cell and adenocarcinoma both in the same patient, even in the same biopsy. So it's always important just to go ahead and send the mutations, and sometimes you'll find it. But for the most part, but the overwhelming majority of squamous cells don't have these particular mutations. You know, immunotherapy combined with chemotherapy is very good for squamous cell, and we do see high levels of response there.
Thank you.
Okay, I'm gonna toss one out. As a patient, because this is a safe space, right? So does it hurt your feelings if I, as a patient, ask you as my doctor for a second to go get a second opinion?
It shouldn't. It does not me, and it should not your doctor either. And this is your life on the line. You know, we're an independent practice. I own the practice. We work with all the different cancer centers around here. I have patients almost on a weekly basis that are going back and forth to MD Anderson for second opinions. They can go there, get an opinion. I can give them their treatment locally. And I work with those doctors. Your doctor should be a collaborator because you know, they have to understand where you're coming from, right? Your life is on the line. You're going to do everything you can to get the best possible treatment. And so doctors leave their ego at the door when they come into the office every day. That's how it should be approached. And I think that's the best for patient care. You know, I'll talk a little bit about my practice. We try to give the best possible environment for treatment. Realize that cancer care is a collaborative effort. I go to meetings almost daily with other doctors like myself, surgeons, radiation doctors. We all sit around and talk about cases like these and kind of put our heads together. And so I think most doctors are very open to collaborating, and if they're not, they really should be.
Great answer. Thank you for that.
All right. Well, I'm going to talk a little bit about my practice and some of the healthcare policy stuff that I'm interested in, but I'll finish at the end. We can still talk more clinical. Happy to do it. This is just a little about my practice. I'm in private practice here in Charlotte. I have 2 offices. We do everything we talked about on the slides: chemotherapy, targeted therapy. We actually have we have one of the few practices that has a DigniCap machine, which you can wear when you're getting chemotherapy to preserve your hair. So if you're taking chemotherapy, you wear it, it cools your scalp down and reduces hair loss. We do all the genomic testing we talked about in clinical trials as well. I know this meeting comes from broad different areas, but we have 2 office locations, one in downtown and South Charlotte. I'm most proud of our staff. We've got over 30 people that work for us. They all care deeply about patient care and I think we deliver really great care in a very personal setting. We have this is a DigniCat machine that I talked about here as well. And so we've been in Charlotte for over 20 years, and really enjoy every day as a great experience for us and the patients.
I would like to give, I believe we have a couple of first-time attendees here because you're speaking this evening, and I would like to give them an opportunity just to say a little bit about you if they'd like to, or whatever. So please go ahead and speak up if you're a first-time attendee and a patient of Dr. Favaro.
Thank you. Yeah, it's been a pleasure. I know this is, it's a personal thing people go through. It really is, and but we love it every day. So I'm going to talk a little bit more about what we do for advocacy. We love to advocate in our clinic, and we've got great staff. This is a Hope for Hair Foundation Gala in February, where I spoke about our DigniCat machine and how that really preserves self-esteem for our patients. I encourage insurance companies to cover it. Right now, Cigna will cover it, and I'm encouraging other insurance companies to do the same. The Pink Tie Guys, which is a male advocacy organization for breast cancer. This is a discussion I had at a race for brain tumor patients, and a discussion at the Rotary Club recently about healthcare in Charlotte. So what's gonna happen in the national debate over healthcare? And this article came out on your left here about this is a little bit more of a breast cancer data because there's more information out there on this. But there was a drug very similar to what we talked about today, a targeted therapy for breast cancer that had extended life for metastatic disease for over a year. And so it's a great drug. We use it for these patients. The cost was $700,000. And there's an article that came out that in one of the national journals that discussed that the addition of this drug was unlikely to provide reasonable value for the money spent in the United States. I think that's the danger I see in our healthcare system is centralized control of healthcare and how that can dictate what drugs you get and what drugs are too expensive. And in our healthcare system, we're nowhere near perfect. But I think the data shows we have the best healthcare system in the world. This is survival data for breast cancer in the United States, and this is basically comparing 30 of the most wealthy countries in the world. And the United States is #1. We have the best survival rate for breast cancer. This is 2017 data, and multiple studies have shown this. And basically, if you compare our healthcare system to all these other countries, the major difference is that, a large part of our healthcare system is private, okay, private insurance, where all these other countries are completely socialized medicine. So basically, the healthcare system is run and controlled by the government. And so what happens there is that certain drugs are deemed too expensive, like this particular drug here for breast cancer. And so those that are in control of the government healthcare system say it's too expensive, we're not going to make it available. And so a lot of things I talk about here in our country that we can give to our patients are just simply cannot be obtained in those other countries, and that leads to lower survival rates. And there's also a big difference in cost. The cost of healthcare to pay to the insurance companies when patients go to hospital-based practices is extremely high compared to the average sale price of these drugs. And so what that leads to is basically just an increase in the cost of care with the consolidation in the healthcare market. So tonight I tried to just kind of give you a little bit. I'm not a healthcare expert, but I tried to give you a little bit of opinions about and data about why our healthcare system is so great. So tonight there's a debate. I got a picture of Pence here and a picture of Senator Harris, and this is a plexiglass. Okay, I found this picture on the internet, and so that's just supposed to be funny. But I'm not in any way taking sides. I think you'll hear this might be a good opportunity for you to hear what healthcare is envisioned from both sides of the aisle to see what your thoughts are. Certainly on the Mike Pence Trump side, they feel like Obamacare is hurting families by increasing the cost of care. And their real focus here is to try to develop lower cost health insurance plans, okay? And whereas the other, the Biden-Harris ticket, and I pulled this off their website, they really believe that Obamacare should be supported and expanded. And they plan to do that by introducing more government-supported healthcare plans if they win the election. So I'm hoping tonight will be a very nice, clear discussion that you can listen to, and I'd be certainly interested to hear your thoughts on how that would affect, either of these plans would affect you as a patient. We do bring some local leaders and politicians into our clinic and to educate them about what it's like to be a patient. And we work with a couple national organizations you can see here. And there's a program. They come in, they sit down in the chair, we pretend like we're drawing their blood, we pretend like we're giving them chemo. We can tell them about the issues we face from a reimbursement standpoint, how we have to deal with insurance companies and Medicare, and the patients can sit next to them and tell them their experience. And that's like by far the most valuable thing that we can do. Yeah. And we also have a program where those patients can be involved. We have the first chapter of this organization called CPAN, which is a patient advocacy network. And we had an event at our office. We brought patients in, we educated them about these healthcare issues. And we actually have a meeting before COVID. We go to Washington, D.C. Every year and bring patients and go to the legislatures, and they can tell their stories. And so you don't have to be a patient of mine to be involved in this. This is Sherry Bradshaw. She's on the call tonight. She's our liaison. Feel free to email her or call our office if you want to be involved, or make sure you're on the list for the next meeting. So I do really appreciate your attention. I know this has been wide-ranging, but I've really enjoyed putting this together, and it's always been great for me to hear your questions and thoughts, and I'm here as long as you want me tonight. So thank you.
Can I say something about Dr. Favaro?
Yes, please.
I've been a patient for almost 2 years, and I can tell you unequivocally that if you put a call into his office, you will receive a call back. It is the most unbelievable experience you'll ever have with their staff. They're lovely people and very caring, and you never feel like it's an inconvenience when you ask a question, and we appreciate that. Thank you, Doctor.
Thank you.
Thank you very much.
Thank you. Well, we admire you for what you go through. I mean, I know this is not what you would choose to do. I just see the courage every day, the courage and the fight, and the drive to live and to get better and to educate yourself. And I'm glad you're here, because I think the more you understand and know what's going on, the better off you are. And that gives you a sense of control and understanding. It's almost, it helps you deal with what you're going through, I think, to educate and to learn. So you're all doing the right thing.
I would like to say something. I'm Dr. Favaro's patient. I was just there yesterday. And I got Dr. Favaro through a second opinion. So someone did talk about that. I had no problem whatsoever getting as many opinions as I wanted. But I've been a patient. It'll be a year the end of October. And my last PET scan in July showed my stage 4 lung cancer is at this point gone. It's very overwhelming. I was a non-smoker, non-drinker, always took care of myself. So it was pretty shocking a year ago to sit in a hospital and them tell me that this is what was going on. But I want to thank you, Dr. Favaro, for saving my life. I really appreciate it.
It's our pleasure. We're lucky. I mean, it's very gratifying. I really appreciate you saying that. And we get up and come in every day because that's exactly what we want to do. It's a lucky spot to be in, to be a cancer doctor 25 years ago versus now. All these different things, all these different options. And the most important thing to me is really keeping our healthcare system healthy so we can continue to have more and more options for treatment. And that's exactly what we have. We've got a lot more than we used to. And they're effective drugs. Our job is to learn how to put them together and make the right decisions for each person. But without the tools, we couldn't do it, right? So, but it's great. It's great to see, and I appreciate what you said.
Any other questions, Dr. Favaro, or comments?
Yeah, I don't have any. I hope everybody continues to be well, be safe, take all the precautions you can. Watch the debate. You can stay up for it.
Thank you so much. This has been an amazing presentation. You just I'm amazed that you got so much packed in and you presented it so, you know, in layman's terms, in patient's terms, and so it was brilliant. And thank you so much. We really appreciate you taking the time.
My pleasure. I'm happy to come back anytime. I really appreciate it. It's been a great experience.